I'm a third year exercise science student, Bathurst CSU, and today I'm presenting on multiple sclerosis. Multiple sclerosis is a chronic demyelinating disease that affects the central nervous system. It's caused by genetic and environmental causes and causes a array of signs and symptoms. Today's presentation will focus on pathophysiology, effect on movement control, potential treatments, and exercise prescription. It is believed that multiple sclerosis is caused by a breakdown in the immune system function resulting from either genetic inheritance or environmental factors that result in demyelination in the central nervous system. The environmental cause that has been proposed include infectious pathogens including chlamydia and human herpes virus. This is based off finding genetic material of microbial agent found in multiple sclerosis lesions. Conversely, the previous concept remained hypothesized as there is lack of supporting data and ambiguity in this area. However, vitamin D intake has been strongly correlated and is supported by the observation of lower levels of multiple sclerosis with high levels of circulating vitamin D. Observation of reduced vitamin D exposure in northern latitude as well has also added risk to individuals. Due to these factors, vitamin D has been proposed as a protective factor. Greater support exists, however, for genetic disposition in terms of the etiology. Lifetime incidence of multiple sclerosis is 0.1% normally, or 1 in 100 in the normal population. Siblings have a 3% risk, and if they are twins, this raises up to 25%. Along with this, work has progressed with the allele identification showing the presence of certain variants with multiple sclerosis have these specific alleles. Multiple sclerosis is considered an autoimmune disease that is triggered by autoreactive T helper cells. Increase in autocorrective T cells due to failure of central tolerance mechanisms or irregular activation of autoreactive cells in the peripheral immune compartment due to failure of peripheral tolerance mechanisms leads to T cell triggered autoimmune tissue inflammation. This increase in T cell activity ends up causing demyelination in the central nervous system. This inflammatory response in the immune system causes T cells to attack oligodendrocytes. Oligodendrocytes are responsible for producing myelin. However, when they attack, cause damage. When they attack, they are damaged and unable to continue their normal function. Oligodendrocytes no longer produce myelin, and patches of demyelination occur that causes plaque in the white matter of the central nervous system. This causes slow or complete blockages in signal transmission, and is through this process where symptoms of multiple sclerosis arise from. An important dynamic of multiple sclerosis is to understand that there are multiple subtypes of multiple sclerosis. Approximately 85% with MS experience a relapsing disease course followed by a continual decline in function. For example, attack may present as simple as tingling in the foot that may be present for a few hours, and then there may be no sign again for months. Symptoms subside when inflammation subsides in the specific area responsible for the symptoms, i.e. lesion in a lower motor neuron, and this will affect the foot. However, recurrent inflammatory episodes eventually lead to demyelination and cause a permanent damage and changes such as uncontrolled movements, and this is defined as the progressive stage. This form of MS is known as relapsing or the remitting form. The primary progressive form approximately affects 10% of people with MS and will suffer no symptoms until the first onset of the disease. These symptoms will not revert, and the course of the disease will run its course with their condition deteriorating as they age. Benign MS will be present in 10 to 15% of sufferers, and this form of the disease they may experience an attack of the disease. However, they will remain stable, like normal, over the decades without the condition becoming progressive or any worse. The condition multiple sclerosis patients generally degresses over time. However, varies on severity and the types as previously discussed. Most cases live normal lifespan, however, within 10 years, Half the people with multiple sclerosis will require a cane to walk, and 15% will be dependent on wheelchair for mobility. MS is also 3 times more prevalent in women as it is in men, due to reasons not well known by research. Most common symptoms occur through reduced vision, double vision, eye movement disorders, degradation of hearing, vestibular hindrance, and slurred speech, caused by high incidence of lesions occurring in the brainstem, directly affecting the cranial nerves. Other symptoms include ataxia, numbness, declining coordination, bladder disorders, sexual dysfunction, and cognitive defects, which all get worse as the individual age. Due to the nature of multiple sclerosis and its presence in the central nervous system, the effect can be widespread and vary dependent on the location of the lesion in the CNS. In terms of movement control, the main effect on movement is balance. In patients with early stages of MS, changes in gait are observed in sufferers through reduced self-selected gait speed and extended double limb support, as well as altered kinematics through reduced ankle motion and muscle recruitment patterns. The mechanisms of temporal spatial gait parameters that are used by patients with MS due to the compromised stability. Without any kind of intervention as discussed earlier, sufferers may rely on a cane or a wheelchair for mobility. The figure above shows changes in brain activation patterns for right hand movements, and the disability level increases as the pictures go to the right. Functional reorganisation is proposed to occur and changes to a greater extent as the disease progresses, as shown by the diagram. This functional reorganisation provides an explanation for the changes in gait and balance witnessed in patients and how it progressively gets worse as the disease progresses. Due to the indiscriminatory nature of multiple sclerosis, anywhere in the CNS can be affected by the disease, including the vestibulocochlear nerve and optic nerve, both of which are crucial for feedback for movement control. With obstruction in the cranial nerves, this affects feedback and causes area in visual perceptual accuracy. And as I said before, this affects movement control as inaccurate sensory information is being obtained, and this is expressed through a decrease in balance. Thermosensibility has been identified as a factor for decreasing exercise level, and it has been held in strong belief that symptoms of MS is exaggerated through physical exertion by an elevation in body temperature, and this has led to a reduced physical activity in multiple sclerosis patients. Due to vastly different symptoms patients can encounter from MS, there is no single approach and attempt to treat the disease, and it has to be individualised depending on the signs and symptoms that are being displayed. The type of MS that the individual experiences also has to be considered. Due to the nature of MS and the damage that occurs to the myelin through the disease process, the condition cannot be cured. However, it can be attempted to be managed, or a reduction in tissue damage can occur. The relapsing remitting form of MS can be reduced in severity through a group of drugs including beta interferons and glatramine acetate, which are used to stop the activation and migration of inflammatory cells across the blood-brain barrier. Although this may extend tissue damage and reduce the severity of MS, and then therefore the onset of the progressive stage of the disease, if the condition has been left until the progressive stage, the disease-modifying drugs will fail to work, and there is no known effective treatment for this stage of the disease as of yet. It has also been proposed that physical interventions such as physiotherapy be employed if MS has been detected in its early phases, so the impairments in gait and balance can be limited. I will discuss how exercise is beneficial in the preceding section. There has been a sustained belief that exercise should be avoided due to the exacerbation of symptoms, including worsening of visual function and increase in fatigue. However, research has indicated that a reduction in physical activity may produce greater weakness, fatigue, and health risks in multiple sclerosis patients, although exercise participation is low due to the previously discussed notion of thermosensibility. In the present day, it is well known that multiple sclerosis patients adapt normally to most types of training and that their fitness levels are going to increase. Of course, this is if their symptoms allow for exercise adherence, firstly, and that exercise should be promoted as a safe and risk-free activity. Exercise prescription for multiple sclerosis sufferers should be based around the ability to achieve or maintain ability to conduct everyday activities and to participate in social and recreational activities. Evidence has shown that people with multiple sclerosis conduct in less physical activity compared to non-sufferers. It's also important to remember that multiple sclerosis sufferers are not vulnerable from other health contraindications that arise from a lack of exercise, including cardiovascular risks, osteoporosis, and diabetes. Exercise decreases the risk profiles connected to cardiovascular disease, along with the risk of deconditioning and disuse, which are components which add to the fatigue component of multiple sclerosis, which is a huge factor when it comes to multiple sclerosis. There is no specific standard for exercise prescription due to the varying effects each patient displays. So therefore, prescription has to be largely individualised. Consideration of the capabilities and limitations of the patient should be based on preliminary exercise testing and the reported symptoms of multiple sclerosis. Modes appropriate Modes appropriate for enhancing cardiovascular endurance include stationary cycling either with arms or legs, aquatic exercise, and treadmill or elliptical trainer for multiple sclerosis patients who are highly functional. The Borg scale, which is a measure of exertion on a scale from 6 to 20, with 6 being no exertion and 20 being maximal, remains the most practical tool to assess exertion levels and to apply exercise intensities. It is suggested by White and Dessendorfer that an intensity of 11 to 14 Borgs being employed when exercising. This aligns with research that has found aerobic capacity to be increased when exercising conducted 2 to 3 times a week for 30 to 60 minutes at a time at moderate intensities, which equates to 60 to 80% of max work rate and aligns with that 11 to 14 on the Borg scale. Strength training can also be incorporated into the program to increase muscle strength and endurance, and thus patients' functionality. Depending on severity of symptoms, will depict what type of weights will be used, i.e. pulling machines, or fixed. Exercise should target legs, back, shoulder, chest and arms with 2 to 3 sets of 8 to 15 reps. Also, if balance is impaired in the patient's seating weighted exercises should be employed. Aquatic exercise is another popular form of exercise for multiple sclerosis patients. It provides advantages for patients whose symptoms are exacerbated by normal exercise due to heat dissipation. Also, water at chest height provides greater support, enabling patients with poor balance to be able to exercise and get limbs through a greater range of motion. Adding weighted devices on the limbs can also be used as a muscle strengthening tool. In conclusion, exercise participation should be encouraged in all MS patients unless the individual is totally incompetent, as improvements will be seen in all forms of multiple sclerosis. It has been hypothesized that an environmental cause may trigger the start of multiple sclerosis. However, evidence shows that it is more of a genetic-based problem, and in this theory is more academically accepted. However, vitamin D does present a protective factor. Multiple sclerosis is considered an autoimmune disease which is triggered by autoreactive T cells that cause autoimmune tissue inflammation, which is preceded by an attack on oligodendrocytes that prevents the reproduction of myelin. This results in patches of unmyelinated axons that cause an obstruction in signal transmission. Symptoms are dependent on the location of the lesion in the CNS and include vision, hearing obstruction, ataxia, loss of bladder control, numbness, slurred speech, and a host of others. The disease is classified into 3 subtypes, with progressive being the most serious form, as it's hardest to diagnose early and signs and symptoms remain present from the time of onset. Main alterations in movement occur through a decrease in balance and change in vision, including double vision and loss due to lesions in the optic nerve. Treatment for the disease is only really effective if treated in the initial stage, and if it's a progressive subtype, then treatment is ultimately hopeless. Virtually all multiple sclerosis patients, if capable of conducting exercise, should, due to the improvements in cardiovascular capacity and strength, if these types of training are employed. Thank you for watching. This is my reference list. Thank you.